Welcome to the Deep Dive. This is where we take complex topics, unpack them, and really give you the essential nuggets of knowledge. Today, we're diving into something that affects so many of us, yet, we often don't look at the details. Skin cancer, particularly in the head and neck region. We've been digging into some really fascinating source material, specifically Chapter 34, Head and Neck Skin Cancer by Michael F. Zaid and Jan Trokel. Our mission today, to give you a solid, actionable understanding of this incredibly common disease. We're talking different forms, surprising causes, the latest on diagnosis and treatment. Think of it as your shortcut to being truly informed on a critical health topic.
It really is critical, and the statistics alone are, well, quite striking. What's fascinating here is just how common it is. Skin cancer is actually the most common cancer affecting people, period. We're talking an estimated 1 million new lesions diagnosed each year in the U.S. alone. So our goal today is to connect these dots for you, make it clear not just what skin cancer is, but why it matters in your daily life, and importantly, what actions you can take.
Okay, let's unpack that right away. When we
Yeah.
say skin cancer, it's not just one thing, is it? Our sources split it into two main groups.
That's right. You've got non-melanoma skin cancer, NMSC for short, and then melanoma. And the critical difference is really their impact. NMSC makes up the huge majority, like over 95% of all skin cancers. And generally, the prognosis is excellent, very high survival rate. But, and this is key, NMSC can be locally aggressive. It might not spread far and wide, but it can cause significant disfigurement and rack up high healthcare costs if it's not dealt with.
Right, so super common, usually less deadly. But then you mentioned melanoma. It's way rarer, only about 5% of skin cancers, right? And even fewer in the head and neck. But the impact is totally different.
Exactly, a stark contrast. Despite being less common, melanoma is responsible for about 75% of all skin cancer deaths. It's tragic, and what's really concerning is that the rate of melanoma is increasing faster than pretty much any other cancer. Estimates suggest it doubles every 10 to 15 years. Think about this. In 1985, the lifetime risk was about 1 in 150 people. Today, it's closer to 1 in 75.
Wow.
So for you, the listener, getting the difference between these two is just vital. Their severity, the treatments, the very different paths.
Okay, let's zoom in on NMSC first then. Within that big 95% category, what are the main types we need to know?
So the NMSCs primarily include basal cell carcinoma, that's BCC, making up about 75% of them, and then squamous cell carcinoma, or SCC, which is about 20%. There are rarer ones too, like Merkel cell tumor, but BCC and SCC are the big ones.
And where do these tend to pop up most often?
Well, epidemiologic studies show that about 75% of NMSCs appear on body areas that get the most chronic sun exposure. So think head, face, neck, the backs of the hands. Makes sense, right?
Yeah, absolutely.
And for BCC specifically, it's even more concentrated. Somewhere between 80% and 93% occur on sun-exposed parts of the head and neck. And a really significant chunk, maybe 26% to 30%, are found specifically on the nose.
The nose, huh?
Uh-huh.
Any trends in who gets NMSC?
It's predominantly seen in white individuals. They make up about 98% of cases. But it definitely occurs in Black and Hispanic populations, too. The risk goes up the closer you live to the equator, logically. And also for people whose jobs or hobbies involve a lot of reflected sunlight, think working around snow, water, cement, even roughing.
Interesting.
And here's another thing. While incidence for BCC and SCC is pretty similar for men and women when they're younger, men over 45 have like 3 times greater incidence of NMSC, specifically SCC.
3 times?
Yeah. Common spots are the ears and nose for men. For women, it tends to be the nose and lower legs.
That's a lot of detail, but it really paints a clear picture. So what does this all mean for the prognosis, the outlook?
Overall, like we said, NMSC has an excellent prognosis. Good news there. However, about 2,000 deaths do occur each year, and 3/4 of those are from SCC that has spread metastasized. Death from BCC is incredibly rare. The metastasis rate is tiny, like 0.00028% to 0.1%. But SCC, unlike BCC, it can grow rapidly and it can metastasize. The overall rate of metastasis is somewhere between 2% and 6%. And if SCC does spread, the 5-year survival rate drops to only about 34%.
Oof. That really underscores why catching it early is so important.
Exactly. Early detection is critical, especially for SCC.
All right, so we understand the types, where they show up. Now for the big question, why does skin cancer happen? Our sources say it's multifactorial, host factors, and environmental factors. Let's start with what's going on inside us. the host factors.
Right. If we connect this to the bigger picture, host factors are all about our individual predispositions, things like our phenotype, our skin type, basically our genetics, any pre-existing lesions, and our immune system.
Phenotype, that's like skin type, eye color, hair color,
Right.
how we react to the sun.
Precisely. Tanning, for example, is actually your body's defense mechanism against NMSC. The amount of melanin in your skin, which is genetically set, directly relates to your ability to tan and how sensitive you are to sunlight. More melanin generally means less UV damage.
And this is where Fitzpatrick's skin types come in, right?
Yeah.
Our source details 6 categories based on how skin reacts to sun.
Exactly. Type 1 is sort of the classic fair skin, light-eyed, redhead, maybe Celtic background, who always burns, never tans, highly susceptible to skin cancer. At the other end, type 6 is African skin, which rarely burns and tans very easily. But what's fascinating here is the trade-off. While resistance to skin cancer increases with the higher Fitzpatrick types, things like scarring keloids, for example, become more obvious.
That's a surprising connection. What about other host factors? You mentioned prior history.
Yes. If you've had an NMSC before, your risk of getting another one within 5 years is significant, somewhere between 36% and 52%.
Wow, that high.
Yeah. And genetics play a huge role too. There are syndromes like basal cell nevus syndrome or Gorlin syndrome that cause lots of BCCs appearing early in life. And then there's xeroderma pigmentosa XP. It's an autosomal recessive disorder where people are extremely sensitive to sun because their DNA repair mechanisms don't work properly. Children with XP often have to live like night people. Literally, we read about summer camps for them where activities start at sundown.
Goodness, night people camps.
Yeah.
That really puts the severity into perspective. And albinism.
Right. Albinism, the absence of melanin, also significantly increases skin cancer risk, especially for SCC.
Okay, what about precancerous spots? Are there things you should watch out for?
Yes, definitely. Actinic keratosis, or AK, sometimes called solar or senile keratosis, is the most common one. If left untreated, there's about a 10% to 13% risk it could turn into an SCC. That's why the American Academy of Dermatology actually recommends treating them.
Makes sense.
And even those hard keratotic growths called cutaneous horns, they can have an underlying SCC in about 10% of cases.
Okay, and the last host factor you mentioned was immunity.
Right. Immunosuppression. If your immune system is weakened, maybe from HIV or because you've had an organ transplant and are on immunosuppressant drugs, your body's natural surveillance system is compromised. This makes individuals much more prone to skin cancers. Renal transplant patients, for example, not only get more SCCs and have metastasized more often, but the tumors tend to show up years earlier than in people who aren't immunosuppressed.
So, a lot going on internally that can raise risk. Now let's switch to the external factors, the environmental culprits. I assume sun is top of the list.
Absolutely. The primary environmental factor is, without a doubt, UV radiation from the sun. We mainly deal with 3 types: UVA, UVB, and UVC. UVB rays are considered the most carcinogenic. They directly damage DNA and also suppress immunity. UVA. Well, it used to be thought of as relatively harmless, maybe just causing tanning, but now we know it enhances UVB's bad effects. It's like a co-carcinogen.
And UVC.
UVC is mostly filtered out by the ozone layer, thankfully, but where the ozone layer is thinning, like over Antarctica and Australia, that means increased UVC exposure and increased risk down there.
Okay, and this brings us back to tanning. What's the verdict on tanning beds from our sources?
They're really explicit about this. The UVA light used in tanning parlors enhances the development of new skin cancers. They even seen cancers in teenagers who use them frequently.
Ouch. Good.
Not good at all. In contrast, they mentioned the California spray tan, the skin dye. That's harmless. And often when you look at the history for both NMSC and melanoma patients, you find stories of like 2 or 3 really bad blistering sunburns in childhood, or maybe 3 or more years of really intense sun exposure.
That childhood sun exposure seems really key. Beyond UV, what other environmental factors are mentioned?
Well, certain chemicals are linked, things like arsenic, polycyclic aromatic hydrocarbons found in soot and tar. Also, psoralins combined with UVA therapy, which is sometimes used for psoriasis, and chronic inflammation. If you have long-term inflammatory skin conditions like old burn scars or chronic ulcers, sometimes called Marjolins ulcers.
Marjolins ulcers?
Yeah, these can develop into SCCs, and sometimes these SCCs are more aggressive, with a higher rate of spreading to lymph nodes than typical sun-induced SCCs. Chronic radiation exposure leading to keratosis is another risk factor.
Okay, a complex mix of internal and external factors. Now, let's swing back to melanoma. We know it's rarer, but deadlier. Who's most susceptible?
People in those lower Fitzpatrick skin types, 1 and 2, are most at risk. Other major risk factors include having a history of 3 or more blistering sunburns.
There's that again.
Yep. Also, tanning bed use, definitely a factor, and that PUVA therapy, Sorlin plus UVA. Genetics also play a role. About 10% of melanoma patients have a first-degree relative, parent, sibling, child who's also had melanoma.
And what about moles? That's always a big concern with melanoma.
It is. If you have a lot of moles, say over 100 common moles, your risk is about tenfold higher. And if you have dysplastic nevi, those are atypical-looking moles, especially if you also have a family history of melanoma, the risk goes up significantly.
Okay.
Congenital nevi, moles you're born with, also carry a small, maybe 4% lifetime risk of turning into melanoma. But here's a really important point. While about 30% of melanomas arise from a pre-existing mole or lesion, a whopping 70% arise de novo.
De novo, meaning?
Meaning they just appear as a brand new spot on previously normal-looking skin.
Wow, 70% are new spots. That's crucial to know.
Yeah.
So what should we look for? Everyone knows the ABCD rule, but you mentioned our sources have some caveats.
Right. The ABCD mnemonic is helpful. Asymmetry, irregular border, color changes or multiple colors, and diameter usually greater than 6 millimeter, about the size of a pencil eraser. It's a good starting point. However, and this is critical, the absence of these classic signs absolutely does not rule out melanoma.
But that's important.
Yeah. Our sources point out something quite sobering. About 40% of board-certified dermatologists and over 50% of other clinicians don't identify melanoma correctly just by looking at it, by clinical intuition alone.
That's actually quite shocking.
Yeah.
So visual inspection isn't foolproof, even for experts.
It's not. Other things to be suspicious of include maybe a pink color appearing in a dark lesion or a spot that persistently itches. Any changing lesion needs attention.
Got it. So intuition isn't enough. How do these lesions typically grow? You mentioned phases.
Yeah, melanoma can start as an in situ lesion, meaning it's confined to the very top layer of the skin, the epidermis. This is often called the horizontal or radial growth phase. It might spread outwards but stays shallow. The real danger starts when it begins to invade deeper into the dermis. This is the vertical growth phase. As it gets closer to blood vessels and lymphatics, it thickens, and its potential to metastasize increases dramatically.
And that depth is key for prognosis.
Hugely key. Prognosis is heavily influenced by the tumor thickness, measured by Breslau's classification, or sometimes the anatomic level of invasion, called Clark's level. For example, lesions less than 0.76 millimeters thick have a really good 5-year survival rate, over 93%. But if the lesion is thicker, say larger than 4 millimeters, that rate drops below 50%.
A huge difference.
Massive. And things like ulceration breakdown of the skin over the melanoma or a high rate of cell division, mitosis, also worsen the prognosis. And if it spreads to distant organs, the 5-year survival rate plummets to around 5%.
Okay, that really highlights the urgency. So let's say you or your doctor spots something suspicious. What's next? Diagnosis. The sources are clear. You need a biopsy.
Absolutely non-negotiable. A biopsy is always needed. You need that tissue examined under a microscope histology for confirmation and to figure out the exact type and characteristics, because those details, as we've discussed, really influence how it's likely to behave, the risk of recurrence, and the potential to spread.
Right. What are the different ways a biopsy can be done?
There are several common techniques. A shave biopsy is quite simple, just shaves off the top layers. It's okay for some things, but it might be too superficial to tell an in situ lesion from an invasive one. And it's generally not recommended if melanoma is suspected because you need the full thickness.
Okay, so not for potential melanomas. What else?
A punch biopsy is often preferred for suspicious pigmented lesions. It takes a small, circular, full-thickness core of skin. This gives you the depth information crucial for melanoma staging. Then there are incisional biopsies, where you remove just a piece of a larger lesion, and excisional biopsies, where you try to remove the entire thing, usually with a small margin of normal skin, maybe 2 millimeters.
Is excisional biopsy better?
It's often preferred for smaller lesions if it can be done easily. And here's a key takeaway for you listening. There's this old myth that cutting into a melanoma can make it spread. Our sources state clearly that incisional or excisional biopsies do not disseminate the tumor. Getting that diagnosis is the priority.
Good to clear that up. Okay, so once it's diagnosed, how is skin cancer treated?
Treatment planning is really comprehensive. It's about correlating the tumor's characteristics, type, size, location, aggressiveness, with the patient's individual factors. Their age, skin history, other medical conditions, social factors, even their cosmetic expectations. It's very personalized.
Let's look at the options. Standard excision seems like a common starting point.
It is. Standard excision involves cutting out the cancer with a safety margin of normal-looking skin around it. The size of that margin depends on the cancer. Like, a small BCC might only need a 2 millimeter margin, while a larger one, say over 2 centimeters, might need 7–10 millimeters, or maybe even Mohs surgery or delayed reconstruction. A challenge here, though, is checking the margins during surgery. Standard practice often uses frozen sections, where tissue is quickly frozen and sliced, but this only looks at representative slices, sort of like random slices from a loaf of bread. You could miss microscopic extensions between the slices.
Okay. So what's the solution if you're worried about missing those extensions?
Well, many surgeons opt for delayed reconstruction.
Delayed reconstruction, what does that involve?
It means the surgeon removes the cancer, sends the whole specimen for standard permanent histology, which is more thorough than frozen sections because they examine the entire margin and then waits for those results, usually a few days. Only once they get confirmation that all the margins are clear do they proceed with the reconstruction, closing the defect.
Ah, I see. What are the benefits of waiting?
Several, actually. First, it gives the highest confidence that all the cancer is gone before you reconstruct. Second, it allows the patient to actually see the defect, understand the scope, and participate more in decisions about cosmetic outcomes. And third, it gives the surgeon time to really plan the best possible reconstruction. It's also shown to be beneficial for skin grafts, as waiting helps prevent blood collecting underneath, which can cause the graft to fail.
Makes sense. And that leads us to what's often called the gold standard, especially for tricky areas. Mohs micrographic surgery.
Yes, MMS, or Mohs. It's a really elegant technique based on two simple principles. Most skin cancers spread contiguously, like roots of a tree, and you have to remove all the cancer cells to get a cure. Unlike standard excision or even delayed closure with standard pathology, Mohs involves the surgeon acting as both the surgeon and the pathologist during the procedure. They remove the visible tumor, map it meticulously, and then examine 100% of the peripheral and deep margins under the microscope while the patient waits. If any cancer cells are seen at an edge, they know exactly where to go back and take just a little more tissue from that specific spot.
So it's incredibly precise.
Extremely. You repeat the process until all margins are clear. This achieves the highest cure rates while preserving the maximum amount of healthy tissue. You're only removing the cancer, not large predetermined margins.
And the cure rates are impressive, you said.
Very. For primary BCCs, especially smaller ones, Mohs cure rates approach 99%. That compares to maybe 90–95% for routine excision with standard pathology checks.
That's a significant difference.
It is. For primary SCC, Mohs boasts 94–99% cure rates versus about 90% for non-Mohs. It's especially valuable for recurrent cancers, aggressive subtypes, large tumors, or cancers in those cosmetically sensitive areas, nose, lip, eyelid, ear, where saving tissue is crucial.
Okay. Are there other ways to treat skin cancer besides cutting it out?
Absolutely. Radiation therapy is an option, particularly for patients who aren't good surgical candidates or for areas like the eyelid or lip where surgery might cause significant functional or cosmetic issues. But it does have potential side effects like skin changes, and the cure rates, especially for melanoma, might not be as high as surgery. It also takes multiple visits.
Right. What else?
There's cryosurgery, basically freezing the lesion with liquid nitrogen. It's inexpensive, quick, and can be effective for small, well-defined superficial lesions. And curettage and electrodesiccation, or C&E, that's where the lesion is scraped away with a sharp instrument called a curette, and then the base is cauterized, burned to destroy remaining cells and stop bleeding.
C&E sounds intense.
It's actually a very common, cost-effective, and quick method, especially good if someone has multiple superficial lesions. But it's blind. You don't check margins microscopically, so it's not suitable for larger, deeper, aggressive, or poorly defined cancers, or in critical areas.
I've also heard about topical creams for skin cancer. How do they fit in?
Yes, topical chemotherapy. Agents like 5-fluorosil, 5-FU, or Miquamud work by medically eliminating surface lesions. They essentially trigger an immune response or directly kill the cancer cells. They can achieve high cure rates for superficial things like AKs, superficial BCCs, and SCC in situ, which is very early SCC confined to the epidermis.
What's the catch?
Well, you need to warn patients, as our sources mention, that there's often an ugly, inflammatory, scabby reaction during the weeks of treatment. It can look pretty raw.
Okay, good to know.
But if the patient is compliant and gets through it, the cosmetic outcome afterwards is usually excellent, often better than surgery for widespread superficial lesions. And then there are other things used in specific situations: lasers, photodynamic therapy, PDT, interferons, retinoids, lots of tools in the toolbox.
So many options. Finally, When a tumor is removed surgically, there's a defect, a hole. Our sources talk a lot about reconstruction.
Right, and this is where surgical artistry really comes in. Understanding skin anatomy, how skin stretches and moves biomechanics is critical. The surgeon has a ladder of options. For small defects, maybe just primary closure, stitching the edges together works fine. For larger or more complex defects, they might need to design a flap, use a skin graft, or sometimes just let the wound heal on its own.
Heal on its own. You mentioned that earlier, secondary intention healing. That sounds kind of passive.
It might sound passive, but it's a valid and sometimes preferred option. It is letting the body heal the wound naturally, filling it in from the bottom up and edges in. It's generally painless, but it can be time-consuming, taking weeks or months depending on the size and location. It's indicated for certain small defects or sometimes larger ones in areas that aren't cosmetically critical, especially in patients who might not want more surgery, or where you really want to keep an eye on the area for any recurrence.
But doesn't it leave a bad scar?
The final appearance can be quite variable, but sometimes surprisingly good, especially in concave areas like the inner corner of the eye. The key is meticulous daily wound care, keeping it clean and moist, usually with ointment and a dressing, to prevent scabbing and allow smooth healing. Our sources actually show this fascinating case. A 60-year-old with a big, rapidly growing SCC on the forehead. Huge defect after Mohs. He opted for secondary intention healing. Took 3 months, healed completely, no recurrence after 2 years, and he decided against any further reconstruction. Just incredible what the body can do.
That is incredible. Okay, but often reconstruction is needed. What about flaps and grafts?
So a flap involves moving a piece of skin and underlying tissue, usually from right next to the defect, that stays attached at one end, keeping its own blood supply. Flaps are great because they bring in tissue that perfectly matches the surrounding skin in color and texture, and they provide good coverage over bone or cartilage. There are many different flap designs: rotation, advancement, transposition.
And grafts.
Grafts are different. You take a piece of skin from somewhere else on the body, the donor site, completely detach it, and place it over the wound, the recipient site. A graft has no blood supply initially. It has to pick up new blood vessels from the wound bed it's placed on, so it needs a healthy, well-vascularized base to survive.
Are there different kinds of grafts?
Yes. Full-thickness skin grafts, FTSGs, include the epidermis and the entire dermis. They tend to contract less and provide better cosmetic results, often matching color and texture well. Common donor sites are behind the ear or near the collarbone. Split-thickness skin grafts, STSGs, are thinner, taking only the epidermis and a partial layer of dermis. They take more easily on less ideal wound beds and can cover larger areas, but they tend to contract more, and the cosmetic match might not be as good. Donor sites are often the thigh or buttock. And then there are composite grafts, which include multiple tissue types, like skin and cartilage together, often taken from the ear, perfect for reconstructing complex structures like the rim of the nostril.
Seems very complex. Are there specific risks with these flaps and grafts?
Yes, beyond the main risk of the tumor coming back, complications related to the reconstruction itself can happen. Necrosis, where part of the flap or graft tissue dies due to poor blood supply, is a major concern. Infection is always a risk with surgery. Hematoma, a collection of blood under the flap or graft, can compromise its survival. And, of course, scarring. And here's where lifestyle choices have a huge impact, something our sources highlight: smoking.
Smoking. How does that affect things?
It dramatically increases the risk of complications, especially flap or graft necrosis-like, triples the risk. Nicotine constricts blood vessels, reducing blood flow, and carbon monoxide in smoke reduces the oxygen-carrying capacity of the blood. It creates a terrible environment for healing tissues that need good blood supply.
Wow, triples the risk. That's significant. What about bleeding?
Bleeding can be an issue, sure, influenced by the patient's overall health or if they're on medications like anticoagulants, blood thinners. Though, interestingly, our sources clarify that for simple procedures like a biopsy, there's generally no need to stop anticoagulants. For major surgery, that's a different discussion between the patient and surgeon.
Okay. This has been incredibly thorough, covering detection, diagnosis, treatment, reconstruction. As we wrap up, let's focus on prevention. Because, as our sources state, and I think this is powerful, the informed patient is the greatest resource against the development of new cancers.
That quote really sums it up, doesn't it? Being informed and proactive is key. So what does prevention look like? It basically boils down to 3 main things: sunscreens, protective clothing, and education. Sunscreens are rated by SPF sun protection factor. It measures how much longer it takes for protected skin to redden compared to unprotected skin when exposed to UV. Regular, consistent use of a broad-spectrum SPF 30 sunblock has been shown to reduce the development of new actinic keratoses by 50% after 3 years.
That's a big reduction.
Yeah.
But SPF isn't a magic bullet, right? Can't just slap it on and forget it.
Precisely. Applying SPF 30 does not negate the need for behavioral changes. It's not an invisibility cloak. Think about that farmer applying SPF 30 in the morning. If they're out sweating in the fields all day, that protection wears off after a couple of hours.
Right.
So reapplication every 2 hours or more often if swimming or sweating is crucial. And seeking shade, wearing wide-blurred hats, avoiding peak sun hours, usually at 10 a.m. to 4 p.m., these are all still vital parts of the strategy.
What about clothing?
Clothing definitely helps. A tightly woven, dry fabric provides good protection. But here's a surprising fact from the sources. A standard wet cotton t-shirt, its SPF might drop to near 0, maybe 1.
Wow, really? 0?
Basically, yeah. So don't rely on a wet t-shirt for sun protection. There is high SPF clothing available now, specifically designed to block UV rays, though it tends to be more expensive. And sunglasses to protect the eyes and surrounding skin are important too.
Okay, so sunscreen, clothing, shade, timing. What's the main message here for our listeners regarding prevention?
It really comes back to being proactive and educated.
Yeah.
The fact that NMSC mortality rates have recently started to level off, maybe even decrease slightly, that's potentially due to public information programs making people more aware. It shows that education works. Knowing your risks, knowing what to look for on your skin, doing regular self-exams, seeing a dermatologist for anything suspicious, and practicing sun safety consistently, that's your best defense.
What an incredibly insightful journey this has been, deep into the complexities of head and neck skin cancer. We've really unpacked the differences between NMSC and melanoma, explored those surprising host factors like genetics and immunity, and the environmental triggers like UV and even chronic inflammation, and navigated the whole process from diagnosis through treatments like standard excision, molasses, topicals, and even that fascinating concept of secondary intention healing.
Absolutely. And I think the core takeaway for you listening is crystal clear. Medical science offers amazing tools, but your own vigilance, understanding your personal risk, knowing the warning signs, and taking those preventative steps every day, that remains your most powerful weapon against skin cancer.
So, thinking about everything we've discussed, the interplay of our genes, our specific skin type, our sun exposure history, it makes you wonder about the future of prevention. Could we move beyond just general advice like wear sunscreen towards truly personalized skin cancer prevention strategies? Imagine maybe advanced genetic screening early in life, identifying specific vulnerabilities, leading to tailored recommendations, maybe even specific nutritional advice or targeted monitoring based on your unique biological profile. It's definitely something to think about. What might that future look like? Something to mull over until our next deep dive. Thank you so much for joining us on the deep dive. We really hope you feel more informed, more empowered, and maybe just a little more curious. Until next time, stay well and keep digging deeper.